right, we're going to get started. Welcome to everyone in the room and welcome to everyone online. I'm Whitney Brown. I work here at the Foundation, and then I'm also part of a local CF Care Center at Inova Fairfax Hospital. And I'm joined by Dr. Natalie West from Johns Hopkins Adult CF Program today. And we are glad that you made the session. You had to walk all the way down the hall. You must be really excited to hear about reproductive health. We're joined by Erin Tallarico and Sophie Cardenas, who are going to help manage questions virtually and from the live audience here. There is a Q&A. If you prefer not to, if you're in the room and you prefer not to raise your hand, you can do the Q&A online and virtually as well. Also, handouts. We have some. It's a little early in the day for some graphic pictures, but you're going to see more. And these are nice handouts that Dr. West was able to help get the images for. So I hope they're helpful, and feel free to take. There's extras back there. Thank you so much. And with that, I will let Dr. West get started. Thank you.
Thank you, Whitney. Yes, good morning. I'm so glad that you have joined us today. I'm very excited to be up here. And yes, we're going to be seeing some images, all cartoons, though, of reproductive anatomy. So first, I'd like to thank the CF Foundation for supporting our sharing working groups. It's a sexual health, reproduction, and gender research working group that I helped found about 7 years ago, I think it is now, with about 4 other women nationally, and we have expanded our group. And these are all the topics in this slide that we have current studies on, manuscripts, we have guidelines, gap papers, et cetera. And so today we're really going to focus on fertility, both from the female and male perspective, as well as pregnancy. But when it comes for the Q&A, all of these topics are up for grabs. Happy to answer anything that you guys have to ask. So first, we're going to focus on fertility in females. So the next slide we're going to start with our anatomy right fresh from the start, which are going to be similar to your handouts. And so what I'd like to do is get us all on the same page about what anatomy looks like in a non-CF individual, and kind of what's missing or what might be different in both men and women with CF. And so looking on your left first with the male anatomy is what I want you to pay attention to, is the vas deferens. So vas deferens is what helps transport sperm from the testes into the epididymis and out of the penis, and so those are present on both sides. And then looking to your right, this is normal female anatomy, and so you have your ovaries, which produce eggs. They travel through the fallopian tubes, and if there's sperm there to greet them, then the sperm can fertilize the egg and implant in the uterus. And here's what's missing or different in a person with CF. So starting on your left, men, and 99% will have absence of the bilateral vas deferens, and so that tube that transports the sperm. And then the females on the right have thickened cervical mucus, thickened mucus in the uterus as well. So kind of, I'm sorry, our slides are advancing on their own, so just so you know. So I'm going to keep coming back when I need to. So sorry about that. And so this is what we're going to talk about. Sperm makes it difficult to kind of swim in the environment. We'll kind of go through that. So fertility in females with CF. So again, similar reproductive anatomy to those female people without CF, but things that affect fertility is CFTR dysfunction. And so we have this thick cervical mucus, and also very acidic environment, so really hostile to sperm. And because of nutritional issues, sometimes there's delayed puberty, delayed ovulation, suboptimal nutritional status. But most females, sorry guys, with CF can become pregnant. But there is about a 35% subfertility rate, which means that infertility means you're trying to have kids for about a year and can't, and subfertility is a little bit less than that. And so when we think of highly effective modulators like Kalydeco, like Trikafta, do we think that there's increased female fertility caused by CF modulators? And so yes, better health, better nutrition. We do know absolutely through studies and by women just telling us there's decreased cervical mucus thickness. And there is a normalized pH from normalizing the bicarb secretion. And so we did note in the ivacaftor trials, which is Kalydeco, that actually 2% of females got pregnant during those clinical trials. And we'll get into a little bit more pregnancy with Dr. Brown. And so I love this image. I think this is really fascinating. These are hysteroscopic images looking at on the left here is prior to ivacaftor, so this is in the uterus, so looking at that thick cervical mucus. 3 months after this woman started ivacaftor, the uterine wall is clear of that mucus and looks very normal. All right. I'm going to turn it over to Dr. Brown.
All right, I think our advancer has a life of its own, so it'll keep us on our toes. So we just saw some of the pictures about what may be happening inside the body in terms of improved fertility modulators, and what this is equated to. This is a slide from our CF Foundation patient registry. This is 2024 report, and what you can see over time on the bottom is years since 2020 all the way through the most recent 2024. And you can see the total number of pregnancies that's reported each year. And, you don't have to be a statistical genius to see there's a big step up between 2019, 2020, basically almost a doubling in the number of pregnancies that's reported. Now, what you may have not seen on other figures like this is the two colors. And this just goes to show us, we know that pregnancy can span 2 calendar years. So just to be real transparent, some of these pregnancies, so all of them in blue are newly reported in the calendar year. And in the green, the pregnancy in the same individual was reported the prior year. So whether it's a new pregnancy or it's just spanning over December to January. So there may be a little bit of double counting, but the bottom line is, even if you account for that, is there is essentially a doubling between 2019 and 2020. And we know that just like in the general population, not all pregnancies are planned. And so this was a study from 11 different U.S. centers from 2010 to 2020, so a little bit before the full impact of the Trikafta baby boom. But this collected there were 263 pregnancies reported, or 26 in 163 different individuals, and 40% were unplanned. And in the general population, that's about, almost half, 50% of pregnancies are unplanned. So that's kind of similar. Obviously, when life goes, perfectly, we'd like to plan all the pregnancies, but we deal with what we can. And what this study looked at is what was the difference in outcomes between those who had planned their pregnancy with CF and those who didn't. And we can see on the left-hand side, this is looking at lung function, FEV1. And the top darker bar is the group of women that had planned their pregnancies. And the lighter gray lower is those who had not. And the 2 time points are before pregnancy and after pregnancy. And this is their lung function. So you can see in both groups there's a little bit of drop. And again, this is before Trikafta, but there's a little bit of drop in lung function that happens after pregnancy compared to before pregnancy. But the lines are parallel, meaning that the unplanned group didn't have more loss of lung function than those who planned their pregnancy. But on the right-hand side, again, the 2 time points of before and after pregnancy, same lines. What we do see is that the unplanned group in the lighter gray had more pulmonary exacerbations after pregnancy. So there was a little bit of a difference there. So when I was looking at this study again, preparing for this talk, I thought, well, even though they weren't on Trikafta by that point, how many were on modulators? And the rates were pretty low at that time. It was like about, actually I have it right here, 20 versus 30%. So the unplanned group actually was 30% were on a modulator, which was probably, again, it would be ivacaftor, Symdeko, or Orkambi. So it wasn't, you can't account for it that one was on modulators and one wasn't. Very low rates of modulator use. And a little bit of a signal that you might get sick more often if you don't plan the pregnancy after pregnancy. Okay, that's just summarizing. And so that study, along with some others, sort of led to, this is the traditional thought around pregnancy in the pre-Trikafta era. This is kind of what I learned earlier in my training, is that women could safely, women with CF safely have children, and it didn't necessarily, we wouldn't expect that it would shorten their life or have dramatic catastrophic results for them, but they might need more treatment for pulmonary exacerbations. There might be a little bit of lung function decline. And then higher rates of gestational diabetes. Gestational diabetes, you guys may know, happens in everyone in the population. To some extent, it's just a risk of diabetes developing during pregnancy that resolves after delivery. Different than CF-related diabetes, which would continue after the pregnancy is over. So higher rates of gestational diabetes among women with CF. And that makes sense because we know there is pancreatic involvement and it's stressing the pancreas a little bit. And so maybe some women become diabetic during the pregnancy and then when they're not as stressed, they don't continue with diabetes. And there were higher rates of C-sections. I think that was something that I had to talk to OBs about earlier in my career, is they would say, oh, I imagine that it's too stressful for your patient to have a vaginal delivery. That would be too stressful. And I said, no, actually that would, if they can do it, if you don't need to have a C-section for another reason, please try for a vaginal delivery because they'll have much less pain with the recovery. The recovery will be faster. And we know that pain sometimes makes you not want to cough if you have a scar down there and then you don't cough, you don't clear your secretions, and that can lead to pneumonia. So actually vaginal deliveries are a good idea when possible. But yet historically we did see that women ended up with more C-sections for a number of reasons. And then we always thought that the infants born to women with CF would be a little bit more likely to be born early and smaller size for gestational weight, so low birth weight. So in the ideal world, like we talked about, it would be great to plan all pregnancies. We know that's not always the case. But if we have the luxury of sitting down and dedicating a whole clinic visit to preconception care, these are the kind of topics that we like to go through. So it is, so when someone says, I'm thinking about ideal scenario, I would like to get pregnant next year. What does that entail? Oops, it's moving on its own. This would be what we talk about. Well, who's your partner? Have they been screened for CF? And then we talk about all the nuances with there's different levels of screening tests. So you can't just assume that a basic screening test will be a 0% that your partner's not a carrier. So we talk about that. We offer genetic counseling, again, ideally in advance, but that doesn't always work out. We talk about sort of the plan for OB. Where would you like to deliver the baby? Which hospital? Do you live close enough to come to our hospital? Usually I like to suggest that maternal fetal medicine, which is also called high-risk OB, that at least there's a consultation at least once, and if not, usually people have a standard OB and then they might see a high-risk OB at certain intervals. So we talk about that expectation. And then we look at nutrition and blood sugar and, basically how's all the aspects of the disease controlled right now. Let's get it as good as we can get moving into the pregnancy. And then what I like to talk about is the plan for the cadence of visits after someone's pregnant with CF clinic, because I would like to see people more often when they're pregnant, because things can change dramatically. So whether that's every month in person, every other month in person with telehealth sprinkled in, it's good to just agree on a plan for the pregnancy regarding CF care with a little bit more intense visits during pregnancy to really make sure best outcomes. And then there's a whole discussion about medications, and I think Randall was talking about, stopping azithromycin or, what medicines to continue when you're thinking of pregnancy or pregnant. And so the discussion usually involves, let's look at all your chronic therapies for CF and weigh the risks and benefits of staying on each of them. So this is just saying none of these, as you guys know, people, there are usually not, or never studies done in pregnant women, with medication. So all of this is based on data that's reported or animal data, or lab data. But we go through the medications and talk about risk-benefit ratio. The one thing that is a little different with vitamins during pregnancy that you guys may not know is that vitamin A levels can be harmful to the fetus. So you actually want to make sure you're not giving too much vitamin A. So if women with CF go on a prenatal multivitamin and they're still taking their CF vitamins at the same rate, then we have to pay attention to that. Usually we drop back on the CF vitamins, so there's not over supplementation with vitamin A. Okay, and then modulators. What about modulators? So we kind of talked about everything we talked about till now was up until the time of Trikafta, including this study. This was a report, I think Dr. West was involved in this, 64 pregnancies before Trikafta, and the green bar is on Kalydeco, and the blue is on Orkambi, and the yellow is on Symdeko. And what you see here is that, just draw your eye to the final one, which is all trimesters. These are women, these are the decisions that women made in these 64 pregnancies about staying on their modulator after a discussion. And so only, about 50% stayed on Kalydeco and Orkambi, and over 80% decided to stay on Symdeko. And then what we found is that, and this again is retroactively just looking back at these pregnancies that had already happened. It wasn't part of a planned clinical trial. But the main question was the miscarriage rate any higher than normal in the population? The answer was no. In these 64 pregnancies, it was actually lower. And what about women who chose to go off of the modulator thinking, I don't want to take chances in exposing the baby? In this group, there were actually 9, and they got worse with their pulmonary symptoms and had to go back on during pregnancy. So this was just some early experiencing that it seemed pretty safe, and some women who tried to go off may change their mind if they get worse and go back on. This was subsequently repeated in a group of women on Trikafta with really seemingly the same results. But what we really needed was a planned clinical trial that followed people with, and gathered the same information at people all around the country about what was happening for women getting pregnant. And so Dr. Taylor in the back is one of the principal investigators. I should have you up here, Jen, to give this section, and graciously gave us these slides, and it's still under analysis, but the Mayflower study that you guys probably heard about enrolled 312 participants, and this was data as of the cut point was September of last year, and at that point there were about 300 infants that were born. And so, what happened with modulator use during this study, about 86% of the people who enrolled in the study were continuously on the modulator throughout pregnancy. So this gave us some good experience, and the majority of those were on Trikafta. And this chart goes on to detail very few discontinued, very few had interruptions, et cetera. So what did this mean for the complications? We talked about, the historic teaching about the higher rates of diabetes, et cetera. But in this planned out study, again, we did see this signal of 16% of the women had gestational diabetes. That's a little higher than the rates in the general population. So again, that makes sense. The pancreas gets stressed during pregnancy in NCF, and so that makes sense. And then they looked at preterm labor requiring a steroid injection, high blood pressure during the pregnancy, and preeclampsia. And those really were pretty similar to the general population. So that was reassuring. And then, so most of the women in the Mayflowers were on Trikafta. And what do we know about Trikafta, how it transfers to the baby and in the umbilical cord? And this was a study that's pretty interesting. You can see across the bottom, ivacaftor, tezacaftor, and elexacaftor. Those are the 3 drugs in Trikafta. And you can, and in each one of those, you can see that at delivery, the blood level in mom, the blood level in the umbilical cord, and the blood level within 48 hours in the infant were tested in a small group of women with CF who were on Trikafta. And you can see across all 3 drugs were present pretty equivalently in the cord blood in the baby and the mom. So there is transmission. The baby is seeing the medication. And then for the subset that went on to breastfeed and had testing of the breast milk about 2 weeks later, still all 3 drugs, you can see all the way on the end, the blue triangle, the red, and the green, you can detect all 3 drugs in the breast milk, although a little bit lower. Okay, so that segues us into breastfeeding. So if we think about the transmission of modulators to the baby during pregnancy or through breastfeeding, I really love, Dr. Taylor, there was someone that worked with you that came up with this, I believe. I really love this figure because it breaks down the different scenarios in which the baby in utero could be exposed to modulators. So the first, we have a mom with CF who has a baby with CF. Second, we have a mom with CF whose baby is a carrier. And we know that women with CF when their child, if it's genetically their child, is going to be either a carrier or have CF. And so these are the different scenarios. And then lastly, a scenario that we talked a little bit about yesterday in the PROTECT study is a scenario where mom doesn't have CF but is a carrier, and the baby is suspected of having CF. So these are the three scenarios in which a baby could be exposed. And so the things that we need to look out for, we think it's generally pretty safe. Again, there's no studies, in pregnant women like we mentioned, but we know that these modulators can impact liver health for the person who's taking them. And so therefore, with baby who's getting them, we want to check some blood work after birth and while they're still breastfeeding at regular intervals to make sure that there's no problem with the baby's liver receiving the medication through breastfeeding. And there's also some animal studies with the ivacaftor component of Trikafta that showed some cataracts in animals when they were taking the medicine. So again, we look for, there is something called congenital cataracts, which is just in the general population where people are born with cataracts, but we need to look a little harder in this group who's been getting the medication to make sure the baby doesn't have cataracts. And then the last thing I'll mention is the newborn screen. So if mom is taking modulator for their own health, let's say they have CF through the pregnancy and they have a baby and they continue to nurse, et cetera, we just saw that there is, the baby has the medication within 48 hours still in the bloodstream and then ongoing if nursing. So the newborn screen, which is the heel stick that looks for signs of CF in the baby, is not reliable in that case, right? Because no problem. It could be pseudo-normalized. So what we always say is you can't take the newborn screening is not valid, and you really have to reevaluate after you're done nursing. Okay. Oh no, it's very it's very relaxing music, and it's a nice segue right back into Dr. West. Well, just like this auto advancer here, yeah. Okay. It's okay. It's okay. So that was pregnancy. We're going to have opportunities. So write down your pregnancy-related questions. We're going to have an opportunity at the end, but we want to also really touch on males as well. So I'll give the podium back to Dr. West to lead us through that.
All right. Good morning to those of you who joined us a little bit later. And yes, the slides have a little bit of a mind of their own, so we apologize. So now we're going to focus on fertility in males. And so one study that was done more recently was just kind of querying children, adults, families of people with CF, and actually 1/3 of males with CF reported they had never been told by anyone that they were infertile. And I still remember my first visit with 2 brothers, and the mom's like going like this. Like, I was like, oh, this has not been discussed. And I was like, okay, here we go. So just kind of making sure that families and us as providers are starting these conversations early. And so 95 to 98% of our males are infertile due to that bilateral absence of the vas deferens. And so ways that we can diagnose this is physical exam. Me as a pulmonologist is not going to be able to recognize if that vas deferens is there or not. So I more rely on semen analysis, or we can also do ultrasound, which is very easy to detect whether that vas deferens is present or absent. One thing I do want to make sure that is very clear, though, just because there's that absence of that tube does not make someone sterile. Infertility just means, hey, we can't get the sperm where we need it to go, but there's lots of things that we're going to discuss that men with CF can have biological children if they choose. One thing that our males do kind of talk to us about is, first of all, males with CF are known to have a smaller volume of ejaculate, and that is because there's CFTR protein in the prostate, which actually forms a lot of the fluid. So when that CF protein's not working, the volume of ejaculate is less. And so we had a small study, about 7 males who did report some testicular pain after starting Trikafta, presumably because now that CFTR protein's working, there was more fluid being made from the prostate, and it causes some pain initially, and I've had that clinically reported as well. So again, how we diagnose it is physical exam, semen analysis, or ultrasound. Mostly we're relying on semen analysis. It shows us presence or absence, but also if there is presence, like how is the sperm doing, how is it moving, what's the count. So the question is, same question that we asked about females, does highly effective modulator therapy, can it improve male infertility? So kind of unlikely, right? Like we're not going to regrow the vas deferens. So there's no cases that we know of rescuing that after starting Trikafta or Kalydeco, for instance. However, there was a study with pregnant ferrets who were homozygous, heterozygous for the G551D mutation. That's the one that very early on that ivacaftor or Kalydeco was first approved for, that actually male ferrets were born with their vas deferens. And there's clinically been some cases as well of baby boys when their mom's on Trikafta being born with vas deferens, and it's quite fascinating. So how can we help our men with CF if they want to have biological children do so? And so we ship them off to our friendly urologists, and they decide which one of these assisted reproductive technologies that they can do. But there's TESI, TESA, PESA, MESA. And so basically all that means is how we are going to extract the sperm, whether by a biopsy or aspiration, and which part of the testicle or epididymis. These, I believe, are all in your handouts as well. So just getting that sperm so we can move on to the next step. So then the next step is their partner, and depending if the partner has any reproductive issues or not, sometimes it's as easy as intrauterine insemination all the way on the right, where we're just injecting sperm at the right time in the ovulatory cycle. Or if their partner needs more help, actually making in vitro, putting the sperm and the egg together and having that, and then inserting that through in vitro fertilization. And so really that involves a lot of testing of the female partner. And so one of our colleagues who's in the sharing group, Tracy Kazmersky, she does a lot of qualitative, quantitative interviewing. And when she did this study almost 8 years ago, she found that 80% of young people with CF, they want to have children in the future. And so this is a very important topic to us, because now that the majority of our people with CF are being healthier, how can we get them there to live their dream? And so one thing I really want to note is there's different ways to get to parenthood. We've talked a lot about being a biological parent, but obviously there's adoption, step parenthood, foster care, surrogacy, which I've been lucky to have all of these options I've seen in clinic, which has been really, really gratifying. And so lastly, what we're going to talk about is the interplay of parenthood and CF. So many of us in the room, I'm sure, have children, and that's such a dream, but also a lot of things that come along with that. And so when you've got someone with CF who's already really having to take a lot of time to care for themselves, is how does that affect the person with CF? And so there was a United Kingdom registry survey before Trikafta, because Trikafta came around 2020, and they looked at health in the year before becoming a parent and then the first year following parenthood, so kind of a first-year parenthood. So what they did see is there was a small decrease in lung function and a decrease in weight as measured by body mass index, and then an increase in pulmonary exacerbations, usually defined as increased symptoms treated with some sort of antibiotics, oral or IV antibiotics. But what was interesting was when they looked at those that were on modulators, the modulators actually mitigated or kind of canceled out the effect on lung function, but not on weight or exacerbations. So prospectively, this is kind of the sister or brother to the Mayflower study. So the Mayflowers, Dr. Brown described to you prospectively following our pregnant women and their children. Dr. Kazmersky is leading the HOPE study, looking at health outcomes of parents with CF, and so we are enrolling them when they become a new parent within about 6 to 9 months, and then following them and their babies over time. So that ends our part, and so now it's your turn to invite Dr. Brown to come up with me. Happy to answer any questions.
One error.
Oh, one error. Oh, and I'm the one that made this slide. Okay. Oh, yeah. So in your handout, the first one's fertility in people without CF. The second graph on the bottom is fertility in people with CF.
Just cross out.
Just cross out the out.
Mm-hmm.
Thank you. And if there's anyone online, we are monitoring the chat, so we can answer anyone online, or if anyone doesn't feel comfortable with this topic and wants to still give us a question through the chat, we can also do that too.
Oh, is this on? Hi, everyone. Okay, we do have one question from our online audience. Are there any differences for someone with CF in puberty and menstruation? And I think this question is probably asking when that starts.
Yeah, so there is a difference. So generally, it's later, just due to nutritional issues. A lot of the time. So a lot of time, puberty is delayed onset, and menstruation is delayed. And so, however, I don't know currently of any studies we have looking at if that is different now. Now that we have 6 years on a highly effective modulator that most people have available to, I suspect that might get better over time.
Dr. Farah, correct me if I'm wrong, but I think we do collect that data in our registry. The age of the medical term is menarche, first period. I don't know if we've looked at that.
Not in a real systematic study, but a registry people are following it, and there may be control.
Yeah. So for those online that maybe can't hear him, Dr. Ferris said that it is being collected in the CF registry, and we haven't looked at it thoroughly yet, but soon to be. And then we've got Dr. Taylor.
Yeah, there was a fellow that worked with myself and Tracy Kazmarowski to look at that question from the registry data, and it looks like it's earlier. But it was a relatively small retrospective study. We haven't looked prospectively, but it does look like it's going closer to the age that we see in the general population.
Nice. Thank you.
And one thing I'll just, on the other end of the spectrum, we're getting a lot of interest and questions around menopause now with our aging population. And a lot of our women in their 40s want to know, are the expectations different? When does perimenopause start, et cetera? So that's an area of interest as well.
Yes. We've got 2 questions for those that are online. We've got 2 questions in the audience, so we're giving them a microphone.
Hi, thank you so much. You mentioned that all women with CF will have either a child with CF or as a carrier. Is that the same for men with CF?
That's a great question that I think needed to be clarified from this morning. So all people with CF have 2 genetic mutations, and they are going to pass down 1. So if we have one individual, let's say it's the mom that has 2 mutations, let's say the father has been screened and doesn't have 2 mutations that are identified, he would pass down a normal one. She will absolutely pass down an abnormal one. So regardless, the kids will be carriers.
Same for men.
And same for men. Yeah. So that's an excellent point, because I always try to counsel my parents, like, hey, down the road, your kids are going to be carriers for sure, and they need to know that for their future children. So.
Better off doing IVF then, so that you can select the embryo?
It still won't matter. So the question was, are they better off doing IVF so they can select the embryo? So to not have a carrier is impossible, because the one that has CF is going to
I guess I'm saying just to try to prevent having one CF.
yes.
The carrier.
Right. So yes. So there are some individuals who have. So the question for the online audience is that can you try to select the embryos that we can genetically see are just carriers and not have 2 copies and therefore a child with CF, and that can be done.
I will say that is, IVF is already expensive and not fully covered by a lot of insurances, not to mention all the stuff we heard about this morning in terms of the burden on both partners. That testing, the pre-genetic testing that we're talking about is an add-on. That is not standardly performed. And some people, choose to do it and others don't. So that I wouldn't, although it's possible, it would be something to be discussed, and would depend on resources available.
And one pearl too is that to make sure that that the significant of the person that does not have CF, when they do genetic testing, to make sure that your CF center is helping you get the correct genetic testing, because some of the tests out there, if you kind of randomly a physician that's maybe not as familiar with CF, they might just test for like 30 of the most common mutations. We know that there's over 2,000, so you need to have the full genetic panel. And so that's an important part. So a lot of times people will already have done that, and I say, okay, well, let me see it. I want to make sure that you do have the full panel. And then the chances of that significant other actually being a carrier, and I don't know exactly, but it's like 0.01%, because there's still mutations that we haven't found out there, so that would be a possibility, but it's so low that that's why a lot of people don't actually test their the embryos, because if they've had this pretty really very thorough test and they're not a carrier, less likely that it's a pretty low chance.
Thank you. Good morning, and thank you for covering this very important topic. I may have missed the data, so my question is, anecdotally, the people many times that we interact with or meet have gone through IVF. So I'm just curious what percentage of CF pregnancies are IVF versus natural conception?
I don't know if we know.
I don't know that I know the data. Jen, you may know. It's a pretty, at least my clinical perspective, what I've seen over.
Yeah.
Well, yeah, so for women, I think it's pretty low because most women are able to conceive naturally, at least in my clinical experience. But men, because 99% are missing the vas deferens, they do need extra help. Jen, do you have?
Yes,
Dr.
there's data out of Israel that they looked at this question, and so about 30 to 35% of women in the pre-Trikafta era had trouble getting pregnant. We don't know what that number is right now, but it's much, much lower because I'm sorry, I was a little bit late, but the Trikafta works on the CFTR protein that's in the cervix, and so it makes it a lot easier for people to get pregnant. So I suspect that that rate is much, much lower than the 30 to 35% it was in the past.
And Dr. Taylor is part of our sharing group. She was our first chair. Has it been 7 years, Dr. Taylor, I think? Yeah.
Hi, thank you again for talking about this. I want to know if there are external services to help with the financial burden of IVF.
I can take that. There are some, so as I mentioned, there are differences in coverage for IVF. You know, some insurances will cover it if there's a medical reason, and CF obviously would meet that, but others, might be an exclusion to the plan and there's no coverage, or there's things, intangibles that are not covered, like the travel, the hotel that we heard about this morning, if you have to travel, and all the other related expenses, the co-pays of the medications, et cetera. What I advise my patients in clinic when they're facing the prospect of doing IVF and thinking about affordability is to talk to Compass, which is our case management service at the CF Foundation, because they will do they not only can look up insurance benefits, but they can refer to different grant programs. So Boomer Esiason, for example, that foundation has a grant that you can apply for. Actually, one of my patients got to go 2 rounds funded through Boomer. And it's not an automatic, it opens and closes and it depends on the demand and the volume. But yes, there are some grant applications. And then another thing that's really important is when it comes to enrollment time in the fall, open enrollment, whether it's you're choosing between your partner's insurance or your own employer-based insurance, or if you're going out on the marketplace and you know in advance, again, in the ideal world, that you want to get pregnant, really looking at the lineup of what's going to be covered is helpful in choosing the plans. And again, Compass can help navigate that because it's complicated stuff. But that's an excellent question. Anything to add?
No, that's perfect. Thank you.
I had a question about, are there any studies about menstruation, and specifically the pain and amount of menstrual flow, and also maybe rates of endometriosis? I have 2 daughters, and they both feel as if theirs is worse than their friends.
Yeah. There are some small studies. We have kind of on some of that topic, there's 2 papers that we published, some case series about particularly hemoptysis during their menstrual cycle, and which we combined kind of case studies from, I think it was 4 to 6 institutions. And so that's very clearly reported to us by women with CF.
That's coughing up blood, just
Oh,
to
sorry.
make sure everybody,
Yes.
yeah.
Yes, coughing up blood. Thank you. And then there's, we've actually been kind of looking into this a little bit more recently. There's some surveys that are validated in the general population for symptoms, so to speak. But I don't think there's any large studies out there that I'm aware of. So, but it is something that we're interested in for sure. Yeah. I think that's a common report.
I have a question about if it's studied the health or viability of the sperm and how, if it's a decreased volume. Or I've talked to adults with men with CF. I have 2 boys with CF, and one in particular was like, maybe your boys should be like banking their sperm now. It might get worse as they get older. Is there any information on that?
Yeah, so it's kind of well known that before Trikafta, the volume for sure is lower, and there can be some issues with viability and how fast they swim and how mobile they are. But the small studies have shown that that's improving on Trikafta. Again, I know that there's a good 7 to 10% of our people with CF who are not eligible, so I don't want to leave those people out. But I don't think I would recommend banking because men make sperm like millions and trillions on a daily basis. So I think eggs are different, but I think there's enough sperm to go around, if I may be so bold.
And if I'm not wrong about that, when fertility treatment is sought, with the fertility group or urologist, they may advise. Remember, we have all the different procedures on the back about the extraction that may play into the semen analysis, the quality, the number, the swimming, and all that stuff may play into how they need to retrieve the specimen. Meaning, is it just a needle, or do they have to do more of a substantial biopsy?
And when we do the semen analysis, we do have instructions for our men to abstain from sex or ejaculation for, I think it's 3 to 5 days, somewhere around there, collecting it in the morning, keeping it warm, that kind of a thing. So there's instructions specifically that we give. So, yeah.
Has there been any information discovered about quality of eggs? I know we've had issues with like the cervical mucus, and that's preventing a lot, but has there been any understanding if there's a difference in the quality of eggs?
I am not aware of any, and Dr. Taylor is agreeing with me. I don't think we've looked at that. Anecdotally, just thinking about my own patients, I don't feel like I see a difference with the egg quality versus the general population, but that's a small number, so not that I'm aware of.
I think a main factor, just like the general population, is aging for women and egg quality. That's probably the number one thing.
Yeah.
That as we get older, egg quality declines. I think evolutionarily, if we look back many years ago, people were having children at much younger ages, and so that's something that impacts all of us. Yeah.
Hello, Abraham Medrano from Washington State. My son is barely 8, going back to the males. I just wonder when will be the good time to starting to testing for the quality of the specimen, or know when he's gonna be fertile. It's any kind of age.
Yeah, and I think we're both adult physicians. We are adults, but we are we take care of adults. Sometimes. So we're not pediatricians, so I will try to put my peds hat on. I would say whenever the child is ready to receive and hear that information. I think at a young age, maybe the sperm collection test could be a little tricky for a child, but it's easy to do an ultrasound to see if the vas deferens are there, and that's a pretty easy thing to do. That's non-invasive and all that. So I would, at least for my young men, I ask, let's say, whenever you're ready to have that test, if they're 18 or older, I kind of explain what is involved, and that can happen really at any time. Dr. Farrer, do you have since you're our pediatrician in the room?
I would just say, based on my experience, when you do have the ultrasound done, it's often best to have it done over on the adult side. The pediatric radiologists and sonographers aren't necessarily used to looking for the vas deferens, and so that's a test that's better actually done on the adult side.
I think Dr. Taylor also wanted to comment as well.
Yes, I'm going to come from my med peds training since I did both of them. So one of the things that we've seen from older literature is that boys that found out later, over the age of 18, were much more likely to be really upset about it. And so the recommendation in the guidelines that we're trying to get published is that people start talking to their kids about it at the same time that they're getting that information in school about sex ed. So around the age of 11, 12, actually getting the test done, like that's up to the child. But one thing I would warn you about is that, or caution you about, is that a lot of males are really stressed about getting that test, even when they know that they're probably infertile, because they don't want to actually have to get that information. So it's really, really important that your son is ready to actually have that information put in front of him. So you can talk to him about it, but whether he actually does the test when he's that young or waits till he's a little bit older and can completely understand the ramifications is probably important to consider.
And one of our colleagues, Dr. Kazmersky, did a great study where she actually asked young kids, teenagers, when do they want to hear this information from? Who do they want to hear this information from? And the resounding kind of answer was either parents or their CF clinic. They really wanted to have that conversation. So whenever you think he's ready to hear it, you can partner with the clinic to kind of help you have that conversation.
The one additional thing I would underline is once they're aware that they are infertile, it's important for care providers, for families to have conversations, though still, around how important it is to protect against sexually transmitted diseases, because the boys sometimes think that, yes, like Kurt when he spoke the other night, yes.
Any more questions online? No?
All right.
Oh, yes.
That last study that you guys referenced on the UK study, I may have missed it, but do you know that they, was it men and women? It would make sense that women carrying the child would have a decrease in all of that, or is it simply being a parent no matter the gender?
The latter. So it was men and women. And so simply being a parent, just trying to take care of yourself, but also another human being. As we all know, it takes a lot to take care of ourselves for people with CF. And so just having that extra time, and parents are going to choose their children over themselves, right? So.
So one of the things that is important to realize is that because, again, I'm a pediatrician as well, kids are really germy, and we know that about a third of pulmonary exacerbations are elicited because you got exposed to a virus. So one of the things that we are looking at in the HOPE study is trying to figure out if that's like one of the major factors. It's not just that you're taking care of your child and yourself, but you're getting exposed to a lot of germs that can cause you to have more exacerbations. So, we actually didn't look at the year of pregnancy, so it was the year after pregnancy, even for the females, and everybody had more exacerbations.
Yeah, and I would say that makes, it's a little bit of a touchy topic for some at this time, but it makes vaccines for respiratory viruses even that much more important. And we know the RSV virus you guys may have heard of that can be real dangerous in infants, but also in older people or people with compromised lungs. That's now available for pregnant women. I think it's given between week 32 and 36 for mom to get vaccinated and pass the antibody passively to the baby. And then all infants now, is that right, Dr. Farrow and Dr. Taylor, get the Beyfortus shot for the first, even healthy, all infants get a shot of an antibody to prevent RSV in their first winter after birth. Some more vulnerable kids can get it for the second winter after birth. And we're hoping that, keeping everyone healthy around the person with CF, whether it's kids, adults, anyone in the house, that's really important, that sort of cocooning effect. And so it's not only important for the person, but who they are living and hanging out with.
think we have 10 minutes till the next session. You guys can take a break. If you had a question that you're too shy to ask, please come up. We'll turn the mics off. Happy to chat anytime. Thank you all.
Thank you.